Good afternoon. Good afternoon and welcome to the UCLA Center for Health Policy Research webinar series. My name is Nadereh Pourat and I am the director here at the center. I'm happy to welcome you to today's seminar, and for those of you who are joining remotely, we provide lunch for those who come, so you might see some folks coming through, and of course we invite you to come at any time during our seminar, our future seminars. So today's talk is on whole person care, improves care coordination for many Californians. For some Californians, successfully addressing their health conditions can be complicated by mental health conditions and social issues, the difficulty in finding a job, the futility in getting affordable housing, the chronic spells of hunger for yourself and your family. But there is hope within the healthcare sector. These problems can be addressed by better coordination of care by providers. In today's center's health policy seminar, Associate Center Director, Dr. Nadereh Pourat, and our colleague, Dr. Emmeline Chuang, who is an associate professor at the UCLA Fielding School of Public Health, will discuss a framework for providing care coordination used to evaluate the whole person care program in California. This program is focused on coordinating medical, behavioral, and social services for high-need, high-use Medi-Cal patients. They evaluated 25 pilot programs in California and today are sharing their interim findings on the design of the infrastructure and processes that mark successful care coordination that can improve patient outcomes. We also invite you to join us again on Thursday, October 24th at noon for our next webinar, the California Health Interview Survey, our 2018 data release. We'll highlight key findings and present an overview of the new topics available, including e-cigarettes, marijuana use, and more. CHIS 2018 data will also become available that day, so be sure to join us for an overview of the new data release. And as always, you can stay informed, and if you're interested in today's slides, you can request them from our communications department at the email address shown on your screen. I do also want to call out Dr. Pourat here to start. Dr. Pourat, as I said, was Associate Director of the Center. She's also Director of the Health Economics and Evaluation Research Program here, a professor and a colleague at the Department of Health Policy and Management at UCLA, and also a professor in dental health at UCLA School of Dentistry. So she's very, very busy, and we're very happy to have her here.
Thank you. Thank you very much, Nadereh, for the introduction. Thank you, everyone, for taking time out of your busy schedules to join us today for this webinar. We are going to talk about a very interesting and important program that the state of California is implementing. And it is in fact part of a bigger effort in California for several years to promote changes to the healthcare delivery system that would benefit the health of the Medi-Cal beneficiaries in the state. So the program that we're actually talking about today is part of this overall effort called Medi-Cal 2020, which is California's Section 1115 Medicaid waiver. This is a mechanism that allows the state of California to make changes to the Medi-Cal program to, as I said, to benefit the Medi-Cal and beneficiaries, and also to achieve some big overarching goals in the state of California and nationally, which have to do with improving how healthcare is being delivered, have to do with what are the outcomes of those improvements in terms of better population health, and also hopefully achieving efficiencies and perhaps some savings to the healthcare system. programs. But today we're talking about the whole person care. So what is the whole person care program? It is designed to improve health and well-being of high-risk, high-utilizing enrollees that are enrollees of Medi-Cal. To actually implement the program, it is designed to increase coordination and delivery of appropriate services to beneficiaries. It's designed to reduce outcomes such as inappropriate emergency department service visits and inpatient utilization or hospitalizations. And it's also designed to improve access to housing and supportive services. And ultimately, all of this is designed to improve the health of the population. So when I said high risk, high utilizing populations, this is who the program is designed to target. These are individuals that are utilizing many emergency department visits, or are in the hospitals, or are going to nursing facilities. They have 2 or more chronic physical conditions. They have severe mental illness or substance use disorders. They are experiencing homelessness or are at risk of homelessness. And there are populations that are recently released from state institutions such as jails and prisons, who also might have lost their connection to the healthcare system, and they come out with specific conditions and they need care and support. Just to bring everybody up to speed, what does this program look like? There are 25 pilots, as Dr. Ponce mentioned, around the state that are participating. The pilots are essentially mostly counties with one exception, and there's usually the state health agency that is leading the effort. But this is a collaborative effort within the county. As I said, they want to promote integration. Therefore, there is a whole group of other partners, including the managed care plans, the local managed care plans, the hospitals, and a whole lot of community providers that are working together to deliver the program, to deliver the services by the program. There is considerable heterogeneity across pilots, and by heterogeneity, we're talking about the variations in the scope of services that the pilots have undertaken, in the number of individuals that they are enrolling into the program, as well as the type of individuals that they've targeted. So those target populations that I was showing you was variable by the counties, who they prioritize, where they want to make those investments. And as you can see, the dollar amounts in terms of the overall budget ranges significantly. It's reflective of the factors that I just mentioned to you. And you can also see that the enrollment really varies. So we are conducting the overall evaluation of this effort in California. This is a statewide evaluation that we are going to complete, hopefully sometime in 2021. The pilot actually ends in 2020, end of 2020. And this is the actual conceptual model that you're looking at. Those arrows tell you the factors we're actually looking at, and this is how the program is expected to achieve its outcomes. So we're going to look at the infrastructure. How did the pilots pull it all together? What are they doing in order to be ready to deliver the services? What they actually do, what is the care they're providing? There's a care coordination they're providing, and they're also, promoting receipt of other types of services under Medi-Cal. What are the outcomes in terms of the population that they actually provided the services to? Did they improve their outcomes? And ultimately, did this lead to reduced costs, those high price emergency visits and hospitalizations? Is there a reduction in those kinds of services, and are there potential savings? And of course, what's the sustainability of this effort? Can pilots maintain some of these efforts after the funding for the program is over? It's a mixed method evaluation. There's a lot of data sources. I'm not going to get into the details of it, but as you can see, it includes a lot of qualitative information and quantitative data that comes from the Medi-Cal claims and encounter data. Okay. A little bit of a preview of some of the information that we are incorporating in our interim findings. Who are the actual populations that are enrolled in the program? You can see that there are a lot of homeless and at risk of homelessness individuals that are enrolled in the program. Everyone who lives in California and nationally knows homelessness is a huge issue we're all facing, and of course, Medi-Cal program is not immune from that either. It's a significant impact and a significant number of people that are homeless under the program. And there also, the other focus is the high utilizer. One thing you need to know about these target population numbers that you're seeing is does not mean that an individual that's a high utilizer is not also qualifying under these other criteria, but this is how the pilots are identifying each individual as their primary focus. A little bit about the enrollment to date. All of our data, as I said, is interim, so we are looking at the data up to the end of 2018. So you can see by that time period, there are about 108,000 or over 108,000 individuals, unique individuals have been enrolled in the program. And then when you look at the monthly enrollment, you can see that by the end of 2018, there were about 60,000, more than 60,000 people enrolled in the program. And a little bit about the services that the pilots are providing. This is not every pilot determined that they needed to do outreach. In other words, they are going outside of the information they have internally within the organization to identify eligible enrollees and enroll them into the program. So that activity, it's about 56% of the pilots are offering those kind of services. But the crux of the program are the two items that are at 100% here. One is care coordination, and the other one is housing support. So they are all providing these specific services. And in addition to that, there are some other services that could be quite important and effective to get the population from the current status of high utilization of services to a better place. And that includes providing benefits assistance, employment assistance, sobering centers and medical respite for these individuals, as well as including some peers to deliver the care. The rest of the presentation is gonna focus on actually care coordination. How are these pilots delivering care coordination? How did they set it up? And how did they succeed in actually delivering the care? And that's going to be Dr. Chung.
Hello, everyone. As Dr. Pourat mentioned, she provided a great high-level overview of whole person care. The rest of this presentation is going to focus specifically on what the pilots have done in the first 3 years of the program related to care coordination. I think it's important to start, before I dive into the results, by what exactly we mean by care coordination. I think we found, even within pilots, sometimes the definition of what care coordination entailed could vary. For the evaluation, we chose to rely heavily on the Agency for Healthcare Research and Quality's definition of care coordination as entailing the deliberate organization of patient care activities and the sharing of information among all participants concerned with the patient's care. In assessing care coordination within whole person care, we conducted a systematic lit review to identify elements that would be needed for doing this type of care coordination across sectors. There's a rich literature suggests that care coordination can reduce care fragmentation, improve care quality and outcomes, but the success of these efforts are often contingent on factors at the patient, care team, organization, and system of care levels. So following this lit review and also informed by our knowledge of whole person care program requirements, we developed a framework in which we identified 8 key elements for infrastructure and for process that we felt would be critical within whole person care. The 4 key infrastructure elements relate to financial incentives, for promoting organizational buy-in and accountability for care coordination among all of the participating partners, staffing that is sufficient for meeting patient needs, data sharing capabilities and as well as the presence of data sharing capabilities and organizational protocols that would help support care coordination activities. Process activities were really aligned with key elements needed to count as care coordination, if you will. And those included conducting a comprehensive needs assessment, developing a care plan that prioritizes patient goals. It also includes actively linking patients to services rather than, simply providing them a list of information and expecting them to go seek it out on their own. It includes use of patient-centered communication strategies that would really engage what are often difficult, hard to reach patients in care. And finally, efforts and strategies to promote accountability among the care team. When we're talking about coordinating health, behavioral health, and social services, this often entails multiple providers, and what strategies have pilots been putting in place to help ensure that accountability for these activities happens. In the slides that follow, I'll talk about each of these specific elements and highlight pilots' progress in each of these areas in a little bit more detail. First and foremost, I want to talk about financial incentives. Current research suggests that one major barrier to this type of cross-sector care coordination can be financial incentives or lack thereof for promoting buy-in to care coordination. In whole person care, we looked specifically at how care coordination services were being funded. So were there risk stratified payment mechanisms in place that took into account provider risk? And also in pilots that chose to contract out services, care coordination services to community partners instead of have the lead entity provide them directly, did their contractual arrangements with those partners include any kind of incentive payments to promote performance? In all pilots, care coordination services were reimbursed using capitated per member per month bundles. However, 11 pilots chose to stratify those bundles based on enrollee risk and tailor services accordingly. A number of pilots also chose to create separate care coordination bundles based on specific target populations and adjusted services accordingly. For example, one county had 2 care coordination bundles, one that was specially focused on recently incarcerated patients or patients have been incarcerated within the last 90 days, and another that was focused on all other eligible enrollees. And so you can see how even within pilots, there could be differences in the intensity of care coordination services that were being offered. 19 of the 20, sometimes the numbers vary on how we're counting the pilots, which is why I hesitate here. But 19 of the 25 pilots chose to contract out at least some or all of the care coordination services being offered. And within that, 14 did indicate that the contracts with community partners included financial incentives linked to achievement of specific outcomes. For example, one pilot chose to incentivize providers based on the percentage of eligible enrollees that had a visit with the primary care provider scheduled within 7 days of hospital discharge. So that's an example of how they try to incentivize certain activities on the part of their community partners. From a staffing perspective, because the enrollees served by the program often have a wide range of needs, we really looked at whether the care coordination staff really seemed to have the capacity to meet that need. So we looked specifically at, who was part of a multidisciplinary care team? Did they have the relevant clinical expertise? Was there inclusion of peers with lived experience to help promote trust and engagement of these populations? And finally, what did the care coordinator's workload look like? And would they be have sufficient availability to effectively engage with the clients being served? As you'll see from this figure, just as Dr. Pourat mentioned the heterogeneity of pilot program services, this was also true of the types of staff that were being used to provide care coordination services. It varied considerably, but in general, what you could say is all pilots chose to typically have frontline staff, not necessarily clinical staff, but someone like a community health worker or a medical assistant provide the bulk of care coordination services. But all of the teams included at least some staff with clinical experience, like a provider, nurse, or licensed clinical social worker, either in a consultation or supervisory role, if not directly part of the care team, to lend necessary expertise. The other piece I would highlight is that, oh, sorry, it's on this slide. At the bottom, you also see that almost 3/4 of pilots also felt it was important to include staff that were considered peers with similar lived experience to that of target populations, particularly pilots serving those who were homeless or at risk of homelessness, or those who were recently incarcerated. And they did so because they felt that that was very important, not only to ensure a patient-centered approach to the care coordination services, but also really to build trust and rapport with target populations who sometimes could be very suspicious of these kinds of programs and services, especially those being offered, often led by a county health entity. The other thing that was very notable is, you'll see here, is that we have this figure here that shows what the caseloads for care coordinators within each pilot looks like. And you'll see a tremendous range here, with some choosing to offer very high intensity, high touch services to a very small number of clients, and others choosing a little bit more of a population health management approach, where it's maybe a little bit of a lighter touch to it, but to a much larger number of people. To some extent, this is affected by the infrastructure supports available within a county, but I think a key point here is we're looking at a mean across all pilots of about 25 enrollees per care coordinator. And if you were to look at some of the variation even within counties, it's important to recall that a number of counties chose to offer different kinds of care coordination bundles that could be risk stratified. And so, as an example here, if you were to look at Contra Costa, you can see a huge range of, about 90 to 350, and what that looks like is, they chose to have a high intensity, a high risk, and a low risk care coordination bundle, and the low risk clients were only receiving, telephonic care management services, and so the ratio was 1 to 350, whereas the high risk clients were receiving in-person field-based services, and that's when the ratio went way down. And so you can see just a little bit of the variation in the caseload here. The other piece that's very important from an infrastructure perspective, and one that, as Dr. Pourat also mentioned, pilots invested significant resources in, relates to the data sharing capabilities needed to support this kind of information exchange across sectors. For pilots that in some cases had not yet fully transitioned, maybe even to electronic health record on the social services side, building these kinds of connections can be very resource intensive and time intensive. And so from our perspective, the 3 elements we really looked at as important for facilitating care coordination activities included the presence of formal agreements that between participating organizations that could define terms and conditions for this kind of information exchange, the use of a universal consent form to help, to allow for sharing of patient level information between relevant providers. And finally, the use of an electronic data sharing platform that would facilitate the actual sharing of, for example, a care plan between participating providers. And there are lots of other types of data sharing elements that we felt we could look at, but these were some of the basics that we felt would be important for allowing the kind of information exchange needed for care coordination to occur. I think one piece I'd like to highlight is that prior to whole person care, almost 30% of pilots had no data sharing agreements with participating partners. And so by the end of 2018, the end of the 3rd year in the program, all pilots reported at least some data sharing agreements with partners, and I would say over half mentioned that they had formal agreements in place with all of their key partners. Also notable was that about, almost 70% of pilots had implemented universal consent forms. A number of them actually chose to segment those so that patients could opt out of sharing specific select information if they chose to. For example, if they didn't want substance use shared, they could opt in for most of the data sharing and just selectively opt out of the pieces they weren't comfortable with. The vast majority of pilots also had an electronic data platform in place that would allow for sharing of at least the comprehensive care plan. The 15% of pilots that didn't have an electronic data platform in place were planning to develop one and had sort of interim systems in place to support data exchange in the meantime. For example, something like SharePoint or Box as a temporary solution before something more permanent could be put in place. I think in terms of usability of these systems by frontline staff, I think that was an area where pilots still, I think at this midpoint, felt that there was room for improvement. As you'll see here, only 38% of pilots indicated that that they were reporting care coordination activities in a single platform. So there's some possibility of, duplicative data entry or need for care coordinators to access more than one system to get all the needed information. And the other piece was only about 38% of, and only 38% of pilots did care coordinators indicate that they had real-time access to shared data that would really allow for proactive activity in response to that data. But all pilots were trying to make strides in these areas. And finally, the last infrastructure component I want to talk about relates to the presence of clear organizational protocols that would help minimize undesirable variation in care and essentially help reduce role ambiguity on the part of care coordinators, especially when they might be seeing clients with very heterogeneous needs and know what to do in terms of referring clients to needed services. And in this case, we looked specifically at whether there were clear protocols in place that didn't necessarily dictate everything a care coordinator needed to do, but provided guidance for when and how specific types of referrals should be made, as well as guidelines for monitoring receipt of services and or tracking outcomes. At this midpoint, we found that almost 2/3 of pilots had protocols for both of these in place. Pilots that didn't have such protocols in place typically mention that the heterogeneity of services were a barrier. And in particular, pilots in which care coordination services were contracted out to a range of different community providers also mentioned that oftentimes those community providers really wanted to dictate their own internal policies and procedures rather than try to agree to a single pilot-wide standard. And so that could sometimes be a barrier to these kinds of protocols in place as well. So moving on from the infrastructure to looking at the specific process elements of care coordination and what pilots were reporting that they had in place. A key hallmark, sort of a central definition of care coordination is typically that care coordinators conduct a comprehensive needs assessment and use that to develop a care plan that really prioritizes patient goals. And so this was almost a basic, right? All pilots were required to conduct a needs assessment and develop care plans within 30 days of an enrollee's enrollment in the program to repeat that process at least once a year. We looked at whether pilots went above and beyond that basic requirement or not. And we found that, almost 2/3 were repeating those needs assessment and updating care plans more than once a year. Some pilots went way beyond and required those be repeated as often as 30 to 60 days or whenever there was a status change for a client in terms of having a service need met. And many pilots reported use of many but not all, reported use of validated instruments to inform the needs assessment process. For a lot of pilots, the lead entities typically being a county health department, sometimes knowing how to assess social needs in particular, what was new. And so some chose to develop homegrown instruments and others chose to rely on existing ones like the vulnerability index, which is useful for assessing risk and prioritizing services for patients that are homeless or at risk of homelessness. Another piece that's important in thinking about care coordination for these high utilizing populations is the specific communication strategies that care coordinators are using to engage them. There is a growing literature that suggests that telephonic care coordination is potentially not as effective for reaching this particular type of population. And so we really scrutinized what the pilots were doing in terms of in-person field-based communication with enrollees and whether that this was taking place more than the once a month required to bill for care coordination services. All pilots included at least some field-based outreach in their interactions with enrollees. And in our interviews with care coordinators in each of the participating pilots, all reported contacting enrollees more frequently than once per month. And essentially, all of the pilots emphasized that field-based outreach was very, very important for identifying, engaging previously hidden populations and homeless enrollees and sort of getting them on board into the program and staying engaged in services. And so this was something that the pilots, if not initially, certainly by 2018, we're all prioritizing in their activities with enrollees. The other piece that's very important in thinking about care coordination processes that I mentioned previously is the use of active referral strategies to connect patients to needed services. So for example, rather than, again, simply providing a list of information and having patients follow up on it on their own, are they potentially directly arranging and scheduling appointments on patients' behalf, helping them fill out applications for benefits, and maybe even accompanying them to appointments, which is above and beyond, but some care coordinators actually mentioned that they would do that to help their clients. Care coordinators in all pilots reported use of active referral strategies, and they were identified as particularly important in pilots that didn't have standardized protocols in place for doing referrals or tracking and following up the status of those referrals. Despite the use of these active referral strategies, I think it is important to note that multiple pilots did note that the limited availability of long-term permanent housing and private behavioral health providers accepting Medi-Cal did limit the success of referral efforts, right? You can coordinate care all you want, but if there's no actual services to provide, that can still be a problem. So the pilots did the best they can, and it's just a known issue in some of the counties. And last but not least, particularly when we're talking about multiple members of a care coordination team, potentially multiple care coordination team, a final piece that's very, very important for effective care coordination is what strategies are in place for ensuring that there's clear accountability for care coordination activities across the care team. All of the pilots were required to identify staff responsible for care coordination. So that's sort of the bare minimum, if you will. But we, in interviews, asked pilots what strategies that they had put in place to promote accountability among the care team and really tried to see what they had in place. All but one pilot reported use of regular care team meetings to promote at least some accountability for care coordination. Some pilots went further in not only doing these regular care team meetings, but also implementing what they called case conferences to allow for shared learning across care coordination teams. So that might involve, identifying a particularly complex case and discussing it as a group so that everyone can kind of learn the lessons from that and apply it in their practices. A number of pilots did, I think, one remaining accountability challenge. This was particularly true in pilots in which there was more than one community partner responsible for care coordination. In some situations, it was possible for enrollees to have more than one care coordinator across assigned organizations. So for example, they might have one main care coordinator for one type of services, and then if they ended up needing another, like substance abuse, there might be a transition that needed to happen where there was another care coordinator at that organization responsible for taking point. At any time when you have these kinds of handoffs, there's risk for people falling between the cracks in the care if the communication isn't decent. And what I would say is while pilots were aware of these potential issues and trying to implement strategies for limiting that possibility, a number of them did admit that there was that risk and the need for more follow-up and developing strategies for ensuring that that kind of gap didn't happen, and it's still a work in progress for some of the pilots. I think overall, I think the key highlight here that I wanted to note is that over these 3 years, these first 3 years, all pilots reported significant strides in improving care coordination for vulnerable enrollees. These first couple years, especially that first year, was spent almost entirely on developing infrastructure. A lot of the some pilots already had a significant amount in place, but some counties were starting from essentially scratch. And so there were significant strides made, particularly in developing infrastructure and sort of meeting some of the basics of ensuring that comprehensive care plans were in place, that, you know, care coordinators were actively linking patients to services, but still some room for improvement in these last 2 years of the program and potentially beyond. I think some of the lessons learned that pilots noted in our conversations with them were first, I think many, particularly those that hadn't previously tried to engage in initiatives like this, really indicated that they had perhaps underestimated the time and resources it took to really develop a strong and sustainable care coordination infrastructure. Especially new partnerships and new data sharing infrastructure, and the amount of time and energy it would take to really develop something substantive. They also really emphasized the importance of person-centered practices that could effectively engage vulnerable patients in care. A number of pilots mentioned that in implementing their programs, they really sometimes encountered hidden populations or surprising populations that they hadn't previously thought that they would be serving, and really drawing those clients into care required often field-based outreach. And some pilots also mentioned that they felt they almost needed to go beyond just care coordination to offering more intensive care management or case management services as well. And finally, pilots also reported really being creative and trying to leverage whole person care resources and partnerships whenever possible. When resources were limited in a community, some counties were able to leverage whole person care to ensure expedited access to services for their enrollees. In other counties, they were able to sort of develop innovative new partnerships to address shortages of certain resources within the community. So one county reported, when they discovered that there was limited availability of housing, they ended up trying to partner with, private homeowners to develop new housing solutions and work accordingly. Before I turn to some questions, as with any study, I just wanted to highlight some limitations of our current data. First, as I've highlighted a few times, this is mid-implement, it's interim data. We're catching pilots 3 years into a 5-year program. And so I've tried to highlight some of the progress made in developing infrastructure and note that pilots are all still continually working to improve what's being done on the ground in terms of the care coordination experience for enrollees. I would also note that we interviewed care coordinators and program managers and other key informants, but we did not actually obtain information on enrollee perceptions of the care coordination that's been received. And I think that's an important perspective that'll be needed in the long run to really evaluate the long-term success. And finally, because care coordination services were reimbursed using these per member per month bundles, we have a sense of what services could be provided within a given bundle, but we're not necessarily able to get patient or individual level data that reflect the details of specific kinds of services received. And that's a little bit of a gap to be aware of as we're thinking about care coordination for this population.
Great, thank you.
Yeah.
So we're, thank you so much. Before we actually go to the question and discussion, I just wanted to have a couple of remarks added to what Dr. Chuang described. I hope that all of this information gives you an appreciation of the scope of this program. This is a very, very impressive and huge undertaking that's happening in the state. And there's a lot of effort by all of these pilots. And I think what it shows you is that there are lots of different pathways to doing care coordination. We're not making a comment on this is exactly the right way to do it or the wrong way to do it. We are showing how it's being done programs that are developed meeting the basic needs of each county, as well as the capacity within the county. They're all trying to get there, but how they get there could vary significantly. We are actually not making an assessment of outcomes at this point. That is something that we hope to do by the end of the evaluation. The program, as you heard, will continue they're now in the 4th year, and then there's another year of implementation. So much more progress needs to be made and will be made up to that point. But you can see that some of the very basic successes of the program are this achievement of breaking down these silos. When you think about the health agency within a county works often on separate tracks from the behavioral health group, works on a separate track from the social services. This program is intending to bring it all together within the county, getting everyone to work towards a common goal. And that's the intent of the program. And I think that there's enough evidence for us to see that a lot of that is happening already. So I'm going to stop there and start the question and answer. Would you join me?
Thank you so much, Dr. Pourat and Dr. Chuang. Is another round of applause for them, please. So I'm going to referee the questions here. We first, hope you can hear me now. Yes. So let's start with any questions from participants in the room.
Thank you. Nadereh and Dr. Chuang, thanks for a great presentation on a obviously very expansive, complex type of a project. That I'm struck in part based upon some experience we've had as part of the dental transformation, which is also part of Medi-Cal 2020, about a structural aspect that it seems to make this all the more challenging with respect to data sharing platforms, right? And I saw that you reported that 85% at least could record a plan somewhere, but only 38% frontline staff. So it's striking. I'm just curious what you're doing to look into that, because it reminds me of sort of what must have been the era before we decided what gauge all the trains, the tracks were going to be for the trains to run on, because interoperability seems to be just this far off dream still. Some progress made, but a long way. And trying to do this at a county level without having a broader infrastructure beneath it strikes me as maybe a little cart before a horse. Sorry, that was Jim Kroll, here at the faculty associate here at the center.
So Dr. Kroll is actually doing one of the pilots under DTI. So this is a question that he's grappling with under that program as well. So, I mean, this is obviously a major ask to get organizations that have worked for silos for many, many years to now bring all of that data into the 21st century idea of health information exchanges that are accessible at point of service at any time, and they get updated, and the infrastructure ask is huge. I agree, but and I think the program did not, I can't speak to the effort, whether it should have been a major infrastructure that was developed prior to do that. But I think we have to get there somehow, and this is one way of trying to get at it. Do you have any comment?
I feel like the whole person care demonstration was unique in some ways, in that unlike a lot of other demonstration projects, it actually allowed some of the funding to be spent flexibly on developing infrastructure. So some of the pilots really came in with a lot of foundation in place, right? One county that was far ahead of the others already had most of the internal partners working on the same electronic health record, which is a little bit like a unicorn for a lot of other counties. But a large number of counties were operating from almost nothing. And so when I mentioned that the first 3 years were really spent developing infrastructure, often that was the data sharing infrastructure specifically. And so, you know, this presentation was focused particularly on care coordination infrastructure, but what I'll add that's bundled in the interim report, which will come out later this year, and feel free to dig into it for the gory details, we did actually do a lot more looking into what was there in place before and what pilots did put in place after the 3 years. And it looks into a range of solutions that they did explore. You know, did they really invest in developing a data warehouse? Did they kind of focus on more local solutions? You know, to what extent did they try something homegrown? How difficult was it to find a vendor? And so a little bit more of that information will be there, and hopefully will provide some lessons learned for other counties that are beginning to grapple with this themselves.
Okay, 2 questions from Ella Johns from our remote audience. The first is, will you track staff turnover, the need for constant recruitment or not? That's the first question.
What I will say is the qualitative, largely qualitative, right? Most of the quantitative data is coming from administrative data. A lot of the qualitative data is reported at the pilot level. I will note that already many pilots in our interviews, Nadereh reports, other qualitative data sources did indicate already that recruitment and retention of staff is an ongoing challenge. And, you know, some of them, again, this is more of interim report material that we didn't want to put the whole evaluation in this small presentation. The issue of staff training is almost a whole chapter on itself, right? What supports do they have in place to kind of address? I think this kind of recruitment and retention challenge is not unique to this initiative. I think it's one that all demonstration projects face. And so looking at a range of strategies used, you know, was there a training institute in place? How much was program specific versus part of a broader infrastructure for developing skill sets of this type of frontline workforce for care coordination across multiple. But I'll just say that yes, it was an issue that pilots grappled with, and they each came up with their own creative solutions for trying to handle it, for better or worse.
And Ella Johns also asks, when you accompany the patients to refer services, is there any attempt to educate patients to ask the right questions and providers to start more participation in their care?
So this was a debate even among the evaluation team, which is that whole person care was intended to fund and support and improve care coordination. But a lot of pilots, and this is where definitions started to vary even across disciplines, where care management and case management go beyond is a much greater focus on this idea of fostering patient self-efficacy, having a little bit more of a health education component. And what I can say is a number of pilots did feel that care coordination alone wouldn't be sufficient, and kind of voluntarily chose to go above and beyond in offering care management and case management services. For the purpose of the evaluation, we felt we needed to stick to looking at just care coordination, but we've noted where pilots have done more, and I think that's something we hope to sort of look at whether it's actually made an impact sort of later in the outcomes assessment component, but we're not quite there yet.
Thank you. Questions in the room? Yes.
My name is Masood Agahi.
Get a mic.
My name is Masood Agahi. I'm in the executive MPH program at UCLA, and also a physician in private practice. My question is, I was looking for specific metrics that were used to evaluate the success of the program, and what are those metrics? And specifically, I was looking for the cost savings, as in theory, this is one of the main incentives to start a pilot and to look forward to reduce those costs, and what specifically are those parameters that will be looked at if they haven't already, and if you have any early results to share with us.
So what you're asking about is the actual, the evaluation activities are not just what you looked at. This was only one element of the program. And we are going to look at the use the Medi-Cal data particularly to look at the outcomes of the program in terms of changes to health of the population as well as utilization of services. So if you remember that slides where it was talking about better care, better health, and lower costs, that was the better health includes changes to specific metrics that the program has. There are quite a few of them where the pilots have to report on, for example, reduction in hypertension and reduction in cholesterol for specific patients that have issues. And then we also look at utilization of services such as emergency room visits and hospitalization. So there are a number of high-level metrics, outcomes that the program is anticipated to achieve, and we will be looking at those using other data. We also are going to think about what else we might look at using all of those quantitative data. But in terms of the qualitative data, we are primarily looking at how they did what they did, right? How do they actually pull this whole program together? So that's care coordination. We're looking at services that they delivered, services and the type of services and what kind of level of effort per person that was put in. So there's a lot of different types of metrics, if you will. Thank you.
Hi. Thank you so much for excellent presentations. I'm Michael Rodriguez, an affiliate of the center as well as the Public Health and School of Medicine. My question is a little broader implications from this study. One of the things that appears to me is that this study does more than take care of complex patients, people who have complex health issues, but it also is moving towards the direction of having the health system be a place that helps to also respond to some of the social and other determinants of health, which, as we know, are the major factors that influence health. But I didn't really hear any language about that, and so I was wondering whether we're talking about two different highways, or we're actually talking about something that has implications to inform the field in that area.
That's a great question, Michael. It is, the program is designed to integrate the healthcare delivery system around individuals and their needs. So, and it's also, as Em mentioned during her talk, it's a cross-sector effort. So we're not just talking about addressing people's healthcare needs, which a lot of times in the past, we've sort of very much focused on patient walks in, let's find out what's wrong with them physically, medically, we'll take care of that, and we move on. But now we're talking about not only are we going to look at the medical needs of the individual, we're also going to look at their mental health needs. We're going to look at their behavioral health, substance use, and what else falls under that umbrella of types of issues that patients face. And then we're also going to deal with the social services. And that is the nod to the social determinants of health, even though we don't use that terminology here. But the intent is that it's not enough to address medical, even behavioral health, mental health, but you also have to see what else, what other context the patients are coming from, try to address those. You saw about 50% of the population are homeless. So homeless individuals, perfect storm perhaps, where everything, all of these different needs that need to be addressed. Otherwise, you're not going to make any difference. You can provide all the good care that you can, you're not going to make a difference in the outcomes in the end.
And I would add, maybe, I'm glad you brought this up because it sounds like we didn't sufficiently highlight this on the front end, but I think a condition of participating in whole person care was that the pilots had to apply as partnerships. And so there needed to be not only a lead entity, a county representative, there also needed to be a Medi-Cal managed care plan to ensure that financial partner buy-in. There also needed to be a behavioral health partner I think a social service partner and community partners. And so that was sort of an embedded feature. I think it couldn't just be focused on the traditional medical sector kind of care coordination. It really needed to be a collaborative effort to sort of address the holistic whole person, and that includes social needs. And you probably noted on the slide with the services, it wasn't just 100% care coordination, it was 100% housing support, and it wasn't necessarily always an initial intent of the program so much as when the counties were doing their needs assessment, that always emerged as a factor, and so ended up being a feature of the program. So I hope that helps clarify that a lot of what we're talking about with relating to the data sharing infrastructure, the financial alignment relates to this across sector health, behavioral health, social service need. So hopefully lessons learned will speak to this.
Okay, we have time for 2 more questions, and actually 2 are posted online. So the first is from Kelly, who thanks you for the presentation, and is asking about if enrollees' perspectives is important in getting the full picture, and providers and perspectives. And are they currently plans to engage enrollees as part of the evaluation?
Not the statewide evaluation. So we are not, I mean, it's a question of bandwidth. It's not a question of are enrollee perspectives not important? Of course they're important. You know, you need to understand, you could provide the services, you need to understand from people who are receiving those services, do they actually get their needs addressed? We don't have the bandwidth to get into that detail, and that was not what we were charged with either. But we do know that a lot of the pilots are actually doing additional, within their own program, they are doing some assessment of the outcomes of their program. I believe some of them are looking at.
Some of them are leveraging additional funding, really trying to look at the factors that influence whether not only patients choose to engage in the program, but their perceptions of the program. And so that data will come out. It's just not something we felt we could take on sufficiently rigorously for a statewide evaluation. I think when we talk about hidden populations, that kind of field-based outreach, that would also be required to collect data from enrollees, and we felt that was a little bit beyond the scope of what we could do well.
So I think related to these hidden populations, Tony Carroll asks, gathering data which reflects the impact of delivering services according to culturally affirmative practices.
We're gathering data on culturally affirmative.
So this is a little bit tricky. You know, we are relying, the quantitative data is primarily from the administrative data. And so we had to rely on the qualitative data, both the reports submitted by pilots as well as the interviews we were able to do with care coordinators to really get a feel for what's happening on the ground. And what I would say is it's not like we were able to individually interview every care coordinator. What I would say is in interviews we did ask the subset that we were able to speak with about what the care coordination practices looked like, if they were able to mention the use of those culturally affirmative practices. But as I mentioned, as one limitation of the study is just because one care coordinator says they're doing something, it's not necessarily an indication that all care coordinators within a pilot are doing that. So
yeah, but you have to remember, what we did mention that the program uses a lot of peers. And I'm not sure whether they're culturally affirmative, but there are, you could argue that this is, in fact, you're trying to provide services from people who understand the needs of the population because they've been there. So is it culturally appropriate? I'd say that a lot of pilots have made an effort to add those kind of individuals and try to get at the needs of those patients the way they can actually relate to and benefit from it.
Great, thank you. And I do have a question about risk stratification. I will look at the website here that we have in the questions to look carefully. So to please, for those of you interested in the slides, we will have them posted, as well as the recording of this webinar on the website. which is back there behind Dr. Pourat, www.healthpolicy.ucla.edu. So thank you again. Let's give our speakers a big hand for such an informative and careful work. And don't forget to join us on Thursday, October 24th for the next noon seminar. We're releasing just 2018 data, California Health Interview Survey data. Thank you.
Thank you.